Next we will move on to ocular injury, mechanical injuries, ocular trauma terminologies. Closed globe injury, in which eye wall does not have full thickness wound but there is intraocular damage. It includes contusion, lamellar laceration. Contusion refers to closed globe injury resulting from blunt trauma. Lamellar laceration is a closed globe injury characterized by a partial thickness wound of eye wall caused by sharp or blunt trauma. Then open globe injury is associated with full thickness wound of sclera or cornea or both. Rupture refers to full thickness wound of eye wall. Laceration refers to full thickness wound of eye wall. Then it includes penetrating injury, perforating injury. Perforating is it is done by sharp object or missile. Intraocular foreign body injury is technically a penetrating injury associated with intraocular foreign body. Extraocular foreign bodies. Common sites and types. Common sites on conjunctiva and cornea. Then common types: industrial workers, in agriculture, other common foreign body. Clinical features: discomfort, profuse watering, redness, pain, photophobia, defective vision. Complication include acute bacterial conjunctivitis. Foreign body and cornea. Treatment: the corneal ulceration, pigmentation. Treatment: removal of conjunctival foreign body, removal of corneal foreign body. Then prophylaxis: industrial agriculture should be advised to use protective glasses. Then cyclists, scooters should be advised to use protective plain glasses or tinted goggles. Then special guards should be put on grinding machines. Use of tools with overhanging margins should be banned. High healthcare education should be imparted especially to industrial agriculture workers. Blunt trauma: causes and pathogens of damage. Modes of trauma: direct blow by fist, tennis, cricket ball. Accident blunt trauma to eyeball also occur in roadside accidents. Mechanics of forces of blunt trauma: direct impact of the globe. It is direct impact. Then compression wave force. B is compression wave force. Then C is reflected compression wave force. It is reflected. The compression wave force is reflected, and 4 is rebound. It is rebounded towards the force. Then mechanism. Then indirect force. It may considerably the compression wave force considerably damage retina, choroid, etc. Then mechanism of damage: mechanical tearing of tissues of eyeball, damage to tissue cells, vascular damage, tropical changes. Traumatic lesions of blunt trauma: closed globe injury, globe rupture injury, extraocular lesions. Closed globe injury: either there is no corneal scleral wound at all or it is only a partial thickness. Contusional injury may vary in severity from a simple corneal abrasion to an extensive intraocular damage. Cornea: simple abrasions, recurrent corneal abrasion, partial corneal tears, tears in descending membrane, acute corneal edema. Simple abrasions. These are very simple abrasions. These are very painful, diagnosed by fluorescent staining. These usually heal up within 24 hours. Recurrent corneal lesion: these may be sometimes follow simple abrasions, especially those caused by fingernail trauma. Recurrent: patient usually get recurrent attacks of acute pain and lacrimation on opening the eye in the morning. Treatment: loosely attached epithelium should be removed by debridement and pad and bandage applied for 48 hours. Partial corneal tears: these may also follow blunt trauma and treated with topical antibiotic. Tear in descending membrane are known to occur in birth trauma. Acute corneal edema may also occur following traumatic dysfunction of endothelial cells. It may associate with descendant folds, stromal thickening. It usually clears up spontaneously. Rarely a deep corneal opacity may be sequelae. Blood staining of cornea. Blood staining of cornea. It may occur occasionally from associated hyphema, raised intraocular pressure. Cornea becomes reddish brown, greenish in color, and later stage simulates discoloration of clear lens into anterior chamber. Sclera: partial thickness scleral wounds may occur alone or in association with other lesions of closed globe injury. Anterior chamber: traumatic hyphema due to injuries of iris or ciliary body vessels. Traumatic hyphema. Then treatment: conservative treatment is aimed at Prevention of rise in IOP, occurrence of secondary hemorrhage. It should be prevented. And surgical treatment, a small high femur usually clears up with conservative treatment. Exudates, these may collect in anterior chamber following traumatic uveitis. Iris pupil and ciliary body, traumatic meiosis, traumatic mydriasis, rupture of pupillary margins. Then radiating tears in the iris trauma, iridodialysis, anti-flexion of iris, retroflexion of iris, traumatic aniridia, iridemia. Angle recession refers to tear between longitudinal circular muscles. It is caused by deepening of anterior chamber, widening of ciliary body band, and gonioscopy. Inflammatory changes, these include traumatic iridocyclitis, hemophthalmitis, post-traumatic iris atrophy, pigmentary changes. Treatment, it consists of atropine, antibiotics, steroids. Lens, osseous ring, concussion cataract. Concussion cataract is traumatic cataract in iridodialysis following contusion injury. Lens, osseous ring, it is a circular ring of brown pigment seen on anterior capsule. It occurs due to striking of contracted pupil margin against a crystalline lens. It is always smaller than size of pupil. Concussion cataract, it occurs mainly due to imbibition of aqueous and partly due to direct mechanical effects of injury on lens fibers. Discrete subepithelial opacity are of most common occurrence. Early rosette cataract, punctate, it is most typical form of concussion cataract. It appears as feathery lines of opacities along the star-shaped suture lines. Late rosette cataract develops in posterior cortex 1 to 2 years after injury. Traumatic zonular cataract, diffuse concussion cataract, early maturation of senile cataract. Traumatic obstruction of lens, it may occur sometimes in young children resulting in aphakia. Subluxation of lens, it may occur due to partial tear of zonules. Rosette shaped cataract following blunt injury. Choroidal rupture following blunt trauma. Dislocation of lens, it occurs when rupture of the zonules is incomplete. Rupture of zonules is complete. It may intraocular or extraocular. Vitreous liquefaction, appearance of clouds, detachment, vitreous hemorrhage, vitreous herniation. Choroid, rupture of choroid. The rupture of choroid is concentric to optic disc, situated temporal to it. Choroidal hemorrhage may occur under the retina or even enter the vitreous if the retina is also torn. Choroidal detachment is also known to occur following blunt trauma. Traumatic choroiditis may be seen on fundus examination. Retina commotion retinae, Berlin's edema, is of occurrence following a blow on eye. Consider area of posterior pole with a cherry red spot in the foveal region. Retinal hemorrhages, these are quite common following concussion trauma. Multiple hemorrhages including flame-shaped, pre-retinal, D-shaped hemorrhage may associate with traumatic retinopathy. Retinal tears, these may follow contusion, particularly in peripheral region. Traumatic proliferative retinopathy, it may occur secondary to vitreous hemorrhage forming tractional bands. Retinal detachment, it may follow retinal tears or vitreoretinal traction bands. Concussion changes at macula. Traumatic macular edema, traumatic macular edema usually followed by pigmented degeneration. Sometimes macular cysts are formed, which on rupture may convert into lamellar or full thickness macular hole. Intraocular pressure changes in closed globe injury. Traumatic glaucoma, commotion retinae followed by blunt trauma. Traumatic glaucoma, traumatic hypertony, traumatic changes in refraction, myopia, hypermetropia, globe rupture. Types of globe rupture: direct rupture, indirect rupture. Direct rupture though early at site of injury. Indirect rupture is more common occurs because of compression force. Clinical feature: rupture of globe may associate with prolapse of uveal tissue, intraocular pressure, accompanying signs. Treatment: repair of tear, postoperative treatment, inoculation. Extraocular lesions, congenital lesion include subcongenital hemorrhage, emotion, lacerated wounds. Ideal lesion: ecchymosis, laceration and avulsion of lids, traumatic ptosis, lacrimal apparatus lesion, dislocation of lacrimal, laceration of lacrimal passages. Optic nerve injuries, orbital injury. Open globe injury, globe rupture, globe laceration, penetrating, perforating intraocular foreign bodies. Penetrating and perforating injury. Modes of injury: trauma by sharp point instruments, trauma by foreign bodies, mechanisms of drainage, mechanical effects of trauma or physical changes, introduction of infection, post-traumatic iridocyclitis, traumatic lesions with management, wounds of conjunctiva associated with conjunctival hemorrhage, wounds of cornea, uncomplicated corneal wounds, complicated corneal wounds. Then intraocular foreign bodies, common foreign bodies respond for such injuries: chips of iron, steel, modes of damage, lesions, mechanical effects, introduction of infection, reaction of foreign bodies, post-traumatic iridocyclitis, sympathetic ophthalmitis. Mechanical effect depend upon size, velocity, type of foreign body. Then location of intraocular foreign body: anterior chamber. In anterior chamber it usually sinks at the bottom. Iris: here the foreign body is usually entangled in the stroma. Posterior chamber: rarely a foreign body may sink behind the iris after entering through pupil. Lens: foreign body may present on the anterior surface or inside the lens. Vitreous cavity: a foreign body may reach here through vitreous roots. Common sites of retention of an intraocular foreign body: anterior chamber, iris, lens, vitreous, retina, choroid, sclera, and orbital cavity. Logarithmic diagrammatic depiction of roots of S of foreign body in vitreous through cornea, pupil, lens, corneal, iris, lens, then cornea, iris, granules. Then we will move on to chalcosis. Chalcosis refers to specific change produced by alloy of copper in the eye. Then mechanism of copper ions from alloy are dissociated electrolytically and deposited under membranous structures of the eye. Unlike iron ions, these do not enter into chemical combination with proteins of cell, thus produce no degenerative changes. Clinical features: Kaiser-Fleischer rings. It is a golden brown ring which occurs due to deposition of copper under peripheral parts of descendant membrane of cornea. Sunflower cataract. It is produced by deposition of copper under posterior capsule of lens. Retina. It may show deposition of golden flakes at the posterior pole which reflect the light with a metallic sheen. Reaction of organic foreign body. The organic foreign body such as wood and other vegetative material produce a proliferative reaction characterized by formation of giant cells. Caterpillar hair produces ophthalmia nodosum which is characterized by severe granulomatous iridocyclitis with nodule formation. Management of retained intraocular foreign body. Fundus photograph depicting intravitreal foreign body. Limbal ring used for localization of intraocular foreign body seen on anterior posterior view of X-ray. Limbal ring method of radiographic localization of IOFB. Then removal of magnetic intraocular foreign body from anterior chamber, the wrong incision, and B is the right incision. Okay, handheld magnet. Removal of magnetic intraocular foreign body from posterior segment. Sympathetic ophthalmitis. Sympathetic ophthalmitis is a serious bilateral granulomatous panuveitis which follows a penetrative ocular trauma. The injured eye is called exciting eye, and the fellow eye which also develops uveitis is called sympathizing eye. The removal of non-magnetic foreign body through pars plana. Incidence of sympathetic ophthalmia has markedly decreased in the recent years. Etiology is still not known exactly. Then predisposing factors. It almost always follows penetrating injury. Wounds in ciliary region are more prone to it. Wounds with incarceration of iris, ciliary body or lens capsule are more vulnerable. It is more common in children than in adults. It does not occur when actual separation develops in injured eye. Pathogens. Various theories have been put forward. Most accepted one is allergic theory. Pathology. Nodular aggregation of lymphocyte, plasma cell, epithelial cells and giant cells. Dale and Fuchs nodules are formed due to proliferation of pigment epithelium. Sympathetic perivascularity, retina shows perivascular cellular infiltration. Clinical feature, exciting eye, it shows clinical features of persistent low grade plastic uveitis. Sympathizing eye, it usually involved after 48 weeks of injury in other eye. Prodromal stage, fully developed stage. Treatment, prophylaxis, early season of injured eye when there is hope of saving useful vision. Treatment when sympathetic ophthalmologist has already supervened. Early incision, conservative treatment of sympathetic ophthalmitis. Chemical injuries. Chemical in mode of chemical injury, domestic accident, agricultural accident, chemical laboratory, chemical warfare, self-inflicted chemical injuries. Alkali burns. Alkali burns are among most severe chemical injuries known by ophthalmologists. It is done by lime, caustic, potash, caustic soda, liquid ammonia. Mechanism of damage produced by alkalis include alkali dissociate and saponify fatty acids. Being hygroscopic, they combine with the lipids of cell to form soluble. Clinical feature can be divided into 3 stages. Conjunctiva shows marked edema. Cornea develops widespread slowing of epithelium. Iris become violently inflamed. Stage of reparation. In the stage, conjunctival corneal epithelium regenerates and there occurs corneal vascularization. Stage of complication. This is characterized by development of symboliferon recurrent corneal ulceration. Acid burns. Acid burns are less serious than alkali burns. Common acid response for burns are sulfuric acid, hydrochloric acid, nitric acid. Chemical effects. Strong acids cause instant coagulation of all protein which then act as a barrier and prevent deeper penetration. Ocular lesions. Conjunctiva and cornea. There occurs immediate necrosis followed by swelling. It is necrosed and slowed out. Grading of chemical burns. Grade 1 clear cornea, grade 2 hazy, grade 3 opaque, grade 4 opaque, no view of iris of pupil. Treatment, prevent further damage, maintenance of favorable condition of rapid and complete healing. Non-mechanical injuries, thermal injuries, electrical injuries, radiation injuries. Then that's all. Thank you.